Thank you everyone for joining us this morning. Welcome to today's presentation. We're going to be talking about Medi-Cal eligibility and updates in 2023. My name is Maura Gibney. I'm the Director of Organizational Development for California Advocates for Nursing Home Reform, or CANR. And today joining me is Pauline Shatara. She's CANR's Deputy Director. First, a little bit about CANR. We have been around since 1983, fighting to protect and expand the rights of older adults and individuals with disabilities in long-term care. We're also a legal services support center. We offer training and technical assistance for IOLTA-funded legal services organizations. And we provide direct services to consumers through our toll-free statewide hotline and consumer education materials that are available on our website. We also engage in policy advocacy and litigation, which has been successful in raising the standards of care in facilities and expanding consumer protections throughout the state. So today we're going to be focusing on Medi-Cal eligibility for specific programs that serve individuals 65 and older and individuals with disabilities. We'll be talking a little bit about Medi-Cal recovery, and also some of the recent and upcoming changes to Medi-Cal, including the 2024 asset limit elimination, the end of the public health emergency, and CalAIM. So first, a little bit about Medi-Cal, just so we all set the baseline. Medi-Cal is California's health insurance program for individuals with limited income and assets. It's known as Medicaid in other states. And Medi-Cal is the only insurance program that pays for long-term coverage in hospitals, nursing homes, and in-home care for programs like IHSS, PACE, or MSSP. And there were many of you who were interested in information about home and community-based services programs specifically. We are going to be covering that in a different presentation coming up in March. I will share that link in the chat in a little bit so that you can put that on your calendar. So a frequent question that we get is, which Medi-Cal program is right for me? There are many different Medi-Cal programs that can be very confusing. One of the things that's helpful is that Medi-Cal helps people to find the right program based on their income, assets, their age, their disability, the type of services that they plan on using. But if income and assets change, you should let your Medi-Cal worker know to see if you qualify for a different program. So if you're at risk of losing your Medi-Cal, you definitely want to talk with the Medi-Cal office. These are some of the common Medi-Cal programs. There are many different ones. These are the programs that CANR most frequently talks to individuals about, particularly older adults and people with disabilities, including MAGI, Modified Adjusted Growth Income Program. This is one of the most common programs for low-income adults across California. The Age, Blind, and Disabled Federal Poverty Level Program. This is very common for people who are 65 and older, or blind or disabled. Both of these programs are tied to the 138% federal poverty level. So the income criteria, requirements rather, change slightly every year. We'll go through what those are. The Medically Needy program, it also has an income criteria, but it is a program for higher income individuals who only qualify with a share of cost. And then finally, long-term care Medi-Cal. This program is only available to individuals who are in a nursing home or some other types of long-term care facilities. Income criteria is not as applicable, and we'll talk about why. It has to do with share of cost, but there are asset limit criteria, which is currently $130,000 for an individual. So this slide is a lot, but it's meant to be more of a kind of cheat sheet for people who are trying to figure out which Medi-Cal program might be right for them. Again, the Medi-Cal office should be helping with this, but I'll quickly go through a couple of these programs. The MAGI program, which is the pink row at the top, I'm giving you some information about the eligibility criteria for each of these programs. So for MAGI, often the reason why CANR does not deal with MAGI is that people cannot have Medicare. There's very strict income guidelines. So an individual cannot have income higher than $1,564 There is no version of Magi with a share of cost, and you cannot use deductions to reduce your gross income. So it's a very strict program. It's really meant for low-income adults. There are no asset limits for Magi. So one of the things that we do see is a challenge for people who, maybe joined Magi when they were younger and have recently turned 65 and are transitioning onto a non-Magi program where there are asset limits. The good news is that that will be changing in 2024. The Age, Blind, and Disabled Federal Poverty Level Program, or ABD FPL, because there's lots of acronyms in the Medi-Cal world. This again is for people who are 65 or older or blind or disabled. There are income guidelines in order to have free Medi-Cal. It's $1,564 for an individual, $2,106 for a couple. Supplemental health insurance policies can lower people's countable income within reason, and we'll talk a little bit about that. There is currently an asset limit. This was a big change last year. So an individual can have up to $130,000 in their asset reserve, and we'll kind of talk about what the asset reserve looks like. A couple can have up to $195,000, and there's some other scenarios depending on the household size and type that could, expand that asset limit. Because this is a community-based program, there are no transfer penalties. So if someone were to make a large transfer, they would still be eligible for this Medi-Cal program. And some couples may be eligible for additional income and asset protection, depending on the type of services that they plan on using. The green row, which is the medically needy program, very similar to the row above, but this is for individuals who don't meet the income criteria and qualify for Medi-Cal with a share of cost. We're going to kind of talk about what share of cost is and how it works in just a minute. Finally, the yellow row at the bottom, this is long-term care Medi-Cal. There's no age restrictions as long as the applicant is in a skilled nursing home. Beneficiaries pay almost all of their income as a share of cost. They only keep a very small amount of a personal needs allowance. And there are asset criteria similar to the two programs above. Now for this program, there is a 30-month look back on transfers of assets that were over the asset limit. So this was an important change that happened when the asset limit increased. Some people's transfers may be, not counted anymore because if they transferred an amount that was within their property reserve, then they were transferring exempt property. So it's always good to get an idea if somebody is planning on doing a transfer before applying for Medi-Cal, to talk to a professional to make sure that there are no transfer penalties and that they don't lose the ability to receive long-term care coverage. Briefly, this is another program. It's called the 250% Working Disabled Program. I will share, we get a lot of calls from people that believe that the program could work for themselves or for their family member or for a client. It's very important to note that in order to qualify for this program, the person has to be able to meet the Social Security Administration definition of disability. And so that means that the disability had to have been determined before age 65. So unfortunately, if you have someone who you're working with who's 75, only recently became disabled in the last couple of years, this program likely would not work for them because they've already kind of missed one of the key eligibility criteria. This would be a great fit for someone who has countable income that's a bit higher than what's required for the Age, Blind, and Disabled program. Countable earnings are below 250% of the federal poverty level. So that's $3,038 for an individual in 2023. Disability-related income is not counted. So this program works really well for someone who's on SSDI because they've got probably a bit higher income, and they do have to show that they're working. The great thing about this program is that how work is defined is really very flexible. So they could be working full-time, part-time, they can be self-employed. They only have to be working about an hour a month with pay. And there's a very broad definition of work. So I think someone at Canner was working with somebody who sold Avon products. I'm not suggesting Avon specifically. I have no investments in Avon, other people who have, done dog walking or childcare. So it's definitely a program to find out more about. If you think that that it might work for you, you could certainly give us a call. So now we're going to cover what is a share of cost. So if someone's countable income is above the income limit for age blind and disabled, they may be eligible for Medi-Cal with a share of cost. Currently, the income cutoff for an individual is $1,564 or $2,106 for a couple. That will increase in April of 2023. It will increase for an individual up to $1,677 and for a couple up to $2,269. So that's a good, a good jump, about a little over $100 for each. So yes.
Somebody had, we had a couple questions. The 1564, it's monthly income, correct?
Yes. So Medi-Cal wants to know what your monthly income is. And they are going to be asking for, the benefit statement, for example, from Social Security or from your pension to show combined income across all income sources.
And that goes into the next question. Does Social Security and spousal VA count towards monthly countable income?
Yes, for these programs, it does. There are, for Magi program, which is very different and not the focus of today's presentation, income and what is counted or not counted is different for some reason. For these programs, most income is counted. A very key exception would be the VA aid and attendance program. So most VA pensions, most VA benefits are counted. If someone is receiving VA aid and attendance benefits, those are not counted. There are some very specific programs. I believe there's one that has to do with Agent Orange payments. That, if you had this very specific type of income, it would be good, again, to talk to somebody, go through what specifically, but generally VA pensions, regular pensions, CalPERS, Social Security, those are all counted for the purposes of determining share of cost. Okay. So the share of cost is the amount of money that someone must pay each month towards their medical related expenses, supplies, equipments, before Medi-Cal will begin to pay. So it works kind of like a deductible. Medi-Cal is supposed to help you figure out your share of costs based on your countable monthly income, but we do see, we do see errors sometimes. So it is good to understand how share of cost is calculated so that you can identify if something has gone wrong. People who are trying to qualify for Medi-Cal without a share of cost may be able to use the purchase of supplemental medical insurance to bring down their countable income. And we're going to talk a little bit in detail in just on some following slides. So first we'll talk about share of cost in the community. So this is someone who either lives at home or in an assisted living facility, not in a nursing home, because share of costs in the community, share of costs in a nursing home, they work differently. So we'll talk about Seth. He's 65, he's single, he lives at home, and he receives $1,900 a month in pension and Social Security benefits. He has $50,000 in the bank, which, thanks to the new asset limit increase, is no longer disqualifies him for Medi-Cal, but his income is a bit higher than the rate for free Medi-Cal, which is currently $1,564. So how do we do the income calculation? And this is not meant to be something that we expect anyone to memorize. This is a calculation that we include on our slides and also in our fact sheets so that people can kind of plug in their own numbers. So first we look at Seth's gross unearned income of $1,900. Medi-Cal allows a $20 any income deduction that's done automatically. And then there's he's left with countable income used to determine his share of cost. The state only allows Seth to keep $600 for his living expenses, and that's called the maintenance need. This number has not been changed in decades. And so Seth's monthly share of costs, the amount that he needs to pay out of pocket every month, would be $1,280. So as you can see, that's quite unaffordable. Living in California on $600, being able to pay his rent and food, and having to come up with out-of-pocket medical expenses every month of $1,280. So how could Seth possibly eliminate his share of cost? First, given Seth's income being so close to the income cutoff, he might be able to use supplemental insurance to lower his countable income. When we look at how far away he is from the income cutoff, he would need to purchase about $316 in insurance to lower his countable income to $1,584. That's with that $20 any income deduction. And insurance types that people commonly purchase include health, dental, vision, supplemental drug policies, long-term care. I've included a link to the Medi-Cal Eligibility Procedures Manual, which is number one, really fun reading, but also has a full list of accepted insurance types so that people can hopefully come up with enough supplemental insurance. There is a limit, however. There's only so much insurance someone can buy. So for some people, this strategy is not necessarily going to work. Some other tactics that people could use to eliminate or reduce their share of cost, if they're living in an assisted living facility, they may be able to get a board and care deduction applied. This helps residents of assisted living facilities reduce or eliminate their share of cost. The board and care deduction works a little bit different than the share of cost calculation, and any income above the $600 maintenance limit is considered unavailable if it's paid to the assisted living facility for care and support. So we advise people to provide the Medi-Cal office with a copy of the admission agreement or whatever most updated document shows what the person is paying every month. This should help the eligibility worker run the calculation and either reduce or eliminate their share of cost. So I've included an example here. Brenda receives $3,500 a month from Social Security. She pays $3,400 a month for her facility. After deducting the $600 maintenance need, Brenda's remaining income that she pays to the facility is $2,800, and it's considered unavailable. This leaves her with a $100 share of cost. So Brenda may have $100 in monthly medical expenses. So for example, I had a caller who was in the same situation. She monthly had about $500, $600 in out-of-pocket prescriptions every month, and she wasn't able to continue paying for those and paying for her assisted living facility. So in this scenario, it really worked well for her because while she had a $100 share of cost, number one, she knew she could meet that share of cost. She's already has these out-of-pocket expenses every month, but she's going to reduce her out-of-pocket expenses. So now instead of paying $500 or $600 out of pocket every month, she pays $100. Anything that she needs that's medically related after that will be covered by Medi-Cal because she met her share of cost for that month. Some options for meeting the monthly share of cost for someone who cannot eliminate their share of cost, and that's quite frequent. We talk to people all the time that have quite large share of cost, $1,200, $1,800. So beneficiaries of the medically needy Medi-Cal program must have out-of-pocket expenses equaling their monthly share of costs before Medi-Cal will cover other costs for services and supplies. So how can people meet the monthly share of costs? They can purchase medical equipment, prescription drugs, medical services, co-pays, doctor's visits. These can include medical costs that Medi-Cal may not cover, such as providers who don't take Medi-Cal, Medi-Cal procedures or treatments that have been denied by Medi-Cal. Paying IHSS caregivers out of pocket is very common. And I'll send the slides after the presentation today, but there's a link on this slide to a brochure that explains how share of cost works with IHSS. And then also home care services that are prescribed by a doctor in addition to approved IHSS hours that may be required for you to remain safely at home. And I'm sorry, I do want to go back to that slide real quickly, just to say that people don't have to meet their monthly share of cost. It's not a requirement. You wouldn't be dropped from the Medi-Cal program. But if you think about share of cost like a deductible, if you haven't met your deductible, then your insurance company is not going to, pay for anything. So similarly, if someone doesn't meet their share of cost for a specific month, Medi-Cal is not going to pick up any additional costs. But for some people, it could work kind of similarly to a catastrophic coverage, for unexpected events, or if there is a month where they have a large, amount of medical expenses. Next, we'll talk about shared costs in a nursing home. So let's say that Seth enters a skilled nursing facility, still the same income. He makes $1,900 a month. He had Medi-Cal in the community, but now that he's in the nursing home, he's going to transition to long-term care Medi-Cal. Seth's gross monthly income of $1,900. He will only get to keep $35 for personal expenses, and everything else will be paid to the nursing home as a share of cost. So this is often a confusing point for people who are familiar with community-based Medi-Cal, or who are not familiar with Medi-Cal at all. They don't know that they are going to owe quite a large share of costs when they go into a nursing home. And Medi-Cal does not take into account what people's bills are, what their mortgage is, any kind of utility bills. There is something called the home upkeep allowance, and I'd be happy to speak to anybody about that in greater detail. But quite honestly, if someone needs to stay in a nursing home for longer than 6 months, and they can't pay their mortgage with $219, then the home upkeep allowance is not going to really work. So this is a very, something that people really need to understand, that it can be very life-changing. They may need, there are people that end up having to sell their home. As far as for the personal needs allowance of $35, residents who receive VA aid and attendance can keep $90 from those benefits. So they end up with a total of $125. And SSI eligible residents can keep $50. So
Laura,
next,
we had a question back on slide 12.
okay, yes.
In Brenda's example, how would deductions, say $164 Part B premium deduction, affect the calculation? Would she still have a share of cost?
No, you're right. You're on the right track. If Brenda was also paying for supplemental health insurance out of pocket, then that would be taken into the calculation. She would not have a share of cost. So you can still use the board and care deduction and use deductions of supplemental health insurance. So let's say, one of the key points, and actually Pauline did tell me to mention this, so I'm glad that whoever this was brought this up. In Brenda's example, if she wants to meet her monthly share cost of $100, that means, she's buying prescriptions every month, she's going to have to submit to Medi-Cal proof that she met her monthly share of cost. Versus, and so, she may be really good with, she may be able to log onto the portal. That may be easy for her. For others, purchasing supplemental health insurance of $100 would mean that Brenda only has to provide one time a year proof that she's paying a monthly insurance premium of $100, versus having to log on every month or submit something every month. So it may be more beneficial for some people that don't like paperwork, don't want to have to deal with communicating with Medi-Cal every month, to just purchase a supplemental health insurance policy of $100 to completely eliminate the share of cost. Were there any other questions on that one?
No, not on that one. Oh, someone did have a question about the rent paid to a board and care facility, if that counts as does that count towards medical expenses instead of housing expenses?
So Medi-Cal currently, we've confirmed with Department of Healthcare Services that they don't separate out the amount, into the rent versus personal care services. They do, our understanding is they take the entire amount that someone is paying monthly and they apply that to the board and care deduction. So that's a good thing. People should just be able to submit something proving what they in total pay the board and care facility in order to get this deduction applied. And if anybody is having trouble at the local office is telling them that they've never heard of a board and care deduction, please do get in touch with Canner. We would really like to know about that. Okay, so I'm going to move on to assets. So we talked a lot about income and how income works, how it's counted, how share of cost works, it's important to remember that income and assets are different. Income is the money that someone is receiving every month or quarter or yearly, but the amount that's coming in. Assets are the things that a person has. So does Medi-Cal count all of your assets? No. Some property is not counted for the purposes of Medi-Cal eligibility. Medi-Cal divides property into two different pots of exempt and non-exempt. Exempt property is not counted when they're looking to determine eligibility, and non-exempt property is counted. So that's a lot of information. So let's go on to specific property types. This is a list of exempt assets for 2023. We do have a fact sheet about this as well on our website. What's number one of the things that people call us all the time is they say, I have a house and it's worth, we live in California and it's worth $1 million. The value of someone's primary residence, fortunately in California, does not matter. Other states, there is something called the DRA. So that might be why people, have heard that the value of the home is very important. But for California eligibility criteria, someone's primary residence is not counted for the purposes of eligibility. Their household goods, their personal items, their jewelry, those things are considered exempt. They're not counted for eligibility. Someone can have one car. IRAs, work pensions, the balances of those accounts can be exempt as long as the person is taking out periodic payments of interest and principal. And there's no requirement on what those payments have to be, what the amount of those payments are. It is important to remember that the withdrawals, the payments, those distributions would be counted as income, but they would help if someone had a very large IRA to possibly, start taking a distribution from the account so that the balance of the account would not be a countable asset. Whole life insurance of $1,500 or less is not counted. Term life insurance is not counted at all. It's very important that people figure out what kind of life insurance they have. Often people don't know. And so one of the things that's key right here is the $130,000 cash reserve. So this is, we're going to talk a little bit more about the property reserve in a second, but this is a huge change from previous years of Medi-Cal eligibility. People can have up to $130,000 in cash, but it could also be cars. It could be anything that, might make them ineligible for Medi-Cal. And then there's also the Community Spouse Resource Allowance. This is available for some spouses and registered domestic partners. We're going to talk about spousal impoverishment in just a second. So first, let's talk about the asset reserve. So this was, again, a huge change. It's $130,000 for an individual, $195,000 for a couple who are both on Medi-Cal, and $65,000 for each additional dependent family member. Under spousal impoverishment, which we'll talk about those rules in a moment, couples can have combined assets of up to $278,620. This is based on new 2023 numbers. And so what's important to know about the asset reserve is that a lot of assets that could have previously made someone completely ineligible, like a second car or a whole life insurance policy worth $30,000, if those items, their value can fit within a person's asset reserve, for example, they have $20,000 in the bank, a second car that's worth $10,000, and a whole life insurance policy worth $30,000, that is less than their $130,000 asset reserve. So, based on it, consider, nothing else, no other complicating factors, they should be eligible for Medi-Cal. So it's a huge change. We're really excited. A lot of people have become eligible because of this change. So what if I'm married or have a registered domestic partner? There are special rules for couples when only one person needs Medi-Cal with home and community-based services or is receiving services in a skilled nursing home that allows spouses, the spouse at home or the domestic partner at home to get additional income and asset protection called spousal impoverishment protections. Under these rules, the spouse who is not on Medi-Cal, who we call the community spouse, they're allowed to keep extra income and assets, but they're only available when one spouse is on Medi-Cal, not both. So what does the income protection look like? The community spouse, the one who's not on Medi-Cal, can keep all the income that they get in their name alone. And even if it's over what's called the EMNA limit. And this is a limit that changes slightly every year. For 2023, it's $3,716. So if the community spouse gets $5,000 a month in income, that's fine. They can have all of that income. They can keep it all. It will not be calculated as part of the share of cost determination. But if their community spouse's income is less than that amount, they may be able to receive an income allocation from the Medi-Cal spouse up to that limit. And I will say this is not, it took me a long time to wrap my brain around spousal impoverishment. So this is really meant to kind of put some ideas out there for people of ways that they, might be eligible for Medi-Cal, not meant to be, you walk away being able to give a presentation about spousal impoverishment. Next is asset protection. There's something called the community spouse resource allowance. This is the amount that the community spouse can have in non-exempt assets. So this is separate from the Medi-Cal spouse's $130,000 asset reserve, their kind of pot. It gives couples kind of an expanded amount of assets that they can apply for, or apply for Medi-Cal and become eligible. One of the important things to know is that Medi-Cal takes a snapshot of the combined assets of the couple at the date of application. So couples don't have to divvy up all their assets, make sure that, this is only in one person's name and the other person's name. As long as together at the point of application, they have less than $278,620 in assets that would, normally make them ineligible. They have a lot of time. It's somewhere in the neighborhood of about 5 months, because it's 90 days from the eligibility date to move the assets around and make sure that the Medi-Cal beneficiary doesn't have more than $130,000 in their name. The community spouse resource allowance is expandable through court order. And the community spouse's IRAs or pensions should not be counted. And any other exempt assets would not be counted. And any assets received by the community spouse after eligibility, like an inheritance or lottery winnings, those should no longer be counted. So it's only at the date of application that the community spouse resource allowance is considered. Okay, so we'll talk briefly about Medi-Cal recovery. We do a lot of presentations about this, so I'm only going to be going over it very briefly. The state may seek repayment from the estate of a Medi-Cal beneficiary after they pass for the cost of services that were paid for by Medi-Cal only if they use the following benefits: primarily nursing home care. There are some people that reside in ICF facilities for people with developmental disabilities, specific home and community-based services that include the ALW, the MSSP program, or the HCBA waiver, and then related hospital and prescription drug services that were provided in a nursing home or through one of the programs listed above. So one key thing to know, we get this call all the time: IHSS will not cause Medi-Cal recovery. Visiting the doctor will not cause Medi-Cal recovery. And so there are a lot of ways to avoid Medi-Cal recovery, but one of the first things we always ask is, did the person, did they ever go into a nursing home? Did they ever participate in one of these programs? No, they just used Medi-Cal for some prescription drugs and to go to the doctor. Then there should not be any Medi-Cal recovery concerns at all. Recovery is limited to those, as I mentioned, who use specific services and were age 55 or older. And it only happens if there are assets subject to probate. So what does that mean? If the person passes away and nothing is left in their name, then there can be no Medi-Cal recovery. Medi-Cal cannot come after, the friend or a neighbor or, their child's assets. It has to be the estate of the person who used the Medi-Cal services. Property will not go into probate if people put the property in living trust, joint tenancies, if they set up their accounts as payable on death accounts, if they're in a life estate. Mobile homes, there can be no Medi-Cal recovery on mobile or other manufactured homes. And if it's a small estate with a value of $184,500 or less in personal property, and that number changes slightly every year, or a limit of $55,425 in real property, then it should not go to probate, and there should be no Medi-Cal recovery. And it's very important to know that if there is a surviving spouse, registered domestic partner, or a disabled child of any age, the Medi-Cal recovery is barred. We have a great guide on Medi-Cal recovery, and we're going to be sharing all of the links that were presented today in a follow-up email after the presentation. If you register for the presentation, then you'll receive that email. Okay, so now we're going to transition over to Medi-Cal updates. Huge change in 2024. You may have already heard the rumors, and we are here to confirm that they are true. The state will completely eliminate the asset limit for non-MAGI programs. So all of the programs that we talked about earlier, long-term care Medi-Cal, medically needy, aged and disabled, federal poverty level program, there will no longer be an asset limit. So it's important to know that right now, there are asset limits that we just talked about, the $130,000 or $195,000 for a couple, but that in January 2024, there will no longer be an asset limit. It is important to note that income guidelines will remain the same. So we saw with the last asset limit change that people really got confused, and they thought that, that a huge amount of people would become eligible. And while there were many people who were able to become eligible for Medi-Cal, or who didn't have to spend down all of their savings to get on Medi-Cal, income is still a factor. And if you remember how we talked about share of cost, you can see how for some people, Medi-Cal may still not be a great fit. The asset limit increases for Medi-Cal only. So unfortunately, SSI rules will stay the same. This means that SSI beneficiaries have to keep their assets still under the $2,000 limit for an individual or $3,000 for a couple. Recovery rules will not change. So we just talked about Medi-Cal recovery. If there are states that are subject to probate, they may be open to Medi-Cal recovery depending on the services that the person used. Again, we have a link to our Medi-Cal recovery guide here. I'll talk briefly about the end of the public health emergency. So the public health emergency has been in place since 2020, the start of COVID. During the public health emergency, now going on, we're now to 3 years of the declaration of the public health emergency. Medi-Cal has not been able to take negative actions such as ending coverage or increasing share of cost. There is an exception for people who went into long-term care. They are allowed to apply a share of cost, but if you are in the community and your income increased during these last couple of years, you should not have seen your share of cost increase. The public health emergency is ending, and so beginning in June of 2023, counties will begin doing their annual redeterminations following their normal annual renewal schedules. Usually your annual renewal date is based on your eligibility date. And so some people who are redetermined in June, we're going to start seeing some people possibly become ineligible in July of 2023. If you're over the new asset limit of $130,000, you came into some money during the public health emergency and your renewal month is not until 2024, you shouldn't lose coverage because they're still not going to be processing any kind of changes until it's your renewal month. So let's say during the public health emergency, you won the lottery and you have $140,000, but your renewal month is not until February of 2024. We just talked about how the asset limit is going away. So in February 2024, Medi-Cal is going to be reaching out to talk with you about what your current income situation is at that time. We are a little worried about some people. For example, there's a couple that I talked to recently. Their annual renewal date is in August. The wife had an aunt pass away. She had, received an inheritance of $180,000, and their renewal date will be in August. So what are their options? They may have to consider spending down some of that money. They also, realistically are looking at losing potential Medi-Cal coverage for September, October, November, December. So we're talking about can you go 4 months without Medi-Cal eligibility? And so those are some of the decisions that people kind of have to make because they would be eligible again in January 2024. Counties will not take any action based on change in circumstances from 2020 through May of 2023. They should only be asking about your current asset and income information. So if you won the lottery in 2021 and you blew it all, that should not matter. It shouldn't change your Medi-Cal now. But make sure that you update your contact information with the local Medi-Cal office and make sure that you always respond to any renewal packets or other communication from the office. Okay, so I'm going to stop sharing my screen, and Pauline is now going to be your presenter about CalAIM.
Okay. And we did have a good amount of questions, but I figured in interest of time, we'd hold them to the end. And then if we don't have time, we'll respond and send the answers out to everybody after the presentation. Okay, let me share my screen. Okay. Sorry, one moment, let me, okay, slideshow. Oh, actually, I don't like that. I did it in presenter view and actually it feels like that's confusing to me. So let me do this over, one moment. Okay, can you see my notes or no?
No.
Okay. Okay, well then I will just keep going this way. Okay, so what is CalAIM? Many of you may have heard of CalAIM. I'm sure the social workers on the call have heard of CalAIM and probably have more experience with it than I do. But if you're a consumer, you may or may not have heard of CalAIM, but you may have been noticing that there are some changes to your Medi-Cal depending what county you're in. So CalAIM is the abbreviation for California Advancing and Innovating Medi-Cal, just in case you wanted to know. And there are a lot of pieces of the plan that will be implemented over a 5-year period. I will not be covering all the pieces of the plan. I'm going to save you that headache. But I will cover some things that may be relevant to the population that we serve. It is an ambitious plan. They plan to assess all the Medi-Cal members through a whole person approach and identify their needs to be able to provide the necessary preventable care and care that they need to reduce negative health outcomes. Some people wonder, what does whole person care even mean? And so that means, your health and wellness isn't limited to your physical health. It's looking at the other factors that could contribute to your health, such as emotional, financial, social, occupational, relationships, all these kinds of things that could affect your health. So they're trying to use a whole person approach and assess each member and determine what kind of services they would need. And they're going to be offering some plans may be offering some services that aren't traditional. They may be going kind of thinking outside of the box and trying to provide additional services that can help provide better health outcomes for people. So one of the major changes with CalAIM is a transition to managed care for 31 counties for people in skilled nursing facilities and people who are on both Medicare and Medi-Cal. A benefit would be 14 optional community supports, and I'll go into that more. And these are going to be for high-risk populations, and something called enhanced case management for high-risk populations. So I'll get more into that as we go on. What is managed care? You'll probably hear me say managed care at least 50 times during this presentation, so I thought I should cover it. So traditional Medi-Cal, or what they might call regular Medi-Cal, was fee for service. And so that means that people were in a fee for service systems. Beneficiaries could see a provider who accepted Medi-Cal, and the providers were reimbursed for each individual service or visit. For Medi-Cal managed care, California pays a third-party health insurance plan a set rate or a capitated rate, or what you might think of as a deductible for each beneficiary, and the plan is responsible for and covering services. So in my example here, Susan lives in Los Angeles County. She was recently asked to choose a managed care plan. Susan chooses LA Care Health Plan. The state pays LA Healthcare Plan a monthly premium. Susan will get all of her services approved by the managed care plan, and she will get her care through providers in the LA Care Health Plan network. Who was impacted by the Medi-Cal managed care transition? It affected many people, but for dual eligibles in the 31 counties listed here, they were transitioned into managed care starting January 1, 2023. So managed care is not new. Actually, prior to January 1, 2023, over 70% of Medi-Cal beneficiaries who are dual eligible, meaning enrolled in both Medicare and Medi-Cal, were already enrolled in Medicare. This is the rest of the counties. So this is January 21, 2023. And so beneficiaries received a letter from Medi-Cal asking them to choose a managed care plan if they were in one of these counties. And on the notice of action, they indicated a date that you had to pick a plan by. And if you don't pick a plan by that date, they choose the plan for you. So you should have received, if you're in one of these counties and a dual eligible or in a skilled nursing facility and not already on managed care, you would have received a packet with some options. And so most people would have received that packet, and it would tell you what date you needed to choose by. So that is something that is still going on. And so that's something that is new and affected Medi-Cal beneficiaries in these counties. Other transitions in 2023, I'm not going to talk a lot about each of these changes. I'm just going to briefly cover what it is. So in 12 counties, beneficiaries who were already enrolled in a Medicare Advantage plan were enrolled in matching Medi-Cal plans under the same parent organization if there was a matching plan. Now, unless you're in one of those 12 counties and you got a letter or notice of action, that probably doesn't mean anything to you. And if you're not in one of those counties, it doesn't really matter to you. And if you are in one of those 12 counties and you haven't yet picked a plan and you have questions, you can always look at the resources below, the My Care, My Choice website, or HICAP, who can give you counseling on Medicare plans. CalMedi Connect is only in 7 counties. Those participants were automatically transitioned within their Medicare Advantage plans to a DSNP and a matching Medi-Cal plan. I'm not going to tell you what a DSNP is unless you really want to know. So if you really want to know, I'll tell you, but otherwise I'll skip that. And then there is, unfortunately, there were some DSNP lookalike plans. And what that meant is there were some Medicare Advantage plans who were serving dual eligibles, marketing to dual eligibles, but not offering the same protections, care coordination, and additional wraparound services. So the federal government has required that these plans be discontinued because they don't offer the same protections. And so the participants that were enrolled in these plans are being transitioned to a DSNP plan with the extra protections into a Medicare Advantage plan offered by the same organization. So if anything, it may be disruptive or confusing, but in the long run, it's good news because they'll get more protections and services. So if you are affected by any of these 3 changes, don't call us. We're not the experts in Medicare, but you can definitely contact the My Care, My Choice website or HICAP to get more information about your Medicare options. January 1, 2024 is when they're going to move people in intermediate care facilities, developmentally disabled facilities. All these types of facilities are actually going to be transitioned to Medi-Cal managed care. So first, in January 1, 2023, they started with skilled nursing facilities. And then in January 1st, 2024, they will move these facilities to managed care. Will this transition affect my Medicare or IHSS? The short answer is no. You can still see your Medicare providers with any Medi-Cal plan. Your Medicare providers do not need to join your Medi-Cal plan. Medicare providers do not need to contract with the Medi-Cal plan to submit claims for Medicare cost sharing. So the main takeaway that you should have from this is that you should not be charged by Medicare providers. If you have Medi-Cal, that's called balance billing, and it's illegal. Medicare providers like doctors and hospitals cannot bill patients with Medi-Cal for cost sharing. So if that does happen, you'll want to contact Medicare because that is incorrect. And IHSS, hours and services will not be changed with your managed care plan. Those hours will still be the same, and your provider can still be the same if you want your IHSS provider to be the same. So these services will not be affected by the transition. Can you request an exemption from managed care? It's possible. It's difficult to get. In most cases, you cannot qualify for an exemption from managed care enrollment after you've been in a managed care plan for 90 days. So you do want to keep track if you did get the packet and you haven't, and you were automatically enrolled into a plan, you want to make sure to try to take the steps to get the medical, to get the exemption if that's something you're interested in. Some people may already have submitted a medical exemption request and it may have been approved. So if you do have a medical exemption request approved and you want it for longer than 12 months, you can also get an extension, but you're going to have to wait until 11 months from your existing medical exemption start date. So Healthcare Options is the organization that will call you and let you know when it's 45 days before your medical exemption ends, and then they will tell you how to ask for an extension. So if you do want a exemption from managed care, you would want to call Healthcare Options, or you could download the form, but I would definitely recommend calling Healthcare Options because from what I've been told, it's a complicated process and hard to get. Counties transitioning to managed care for skilled nursing. This is just a map to give you an idea of how many counties were already transitioned into managed care for long-term care in a skilled nursing facility and how many are moving to managed care for skilled nursing. So one of the main concerns that people have with this transition from fee-for-service Medi-Cal to managed care is continuity of care, meaning what if the managed care plan I'm in, get put in or pick, doesn't contract with the facility I'm in? So there are continuity of care plan protections. Beneficiaries in a skilled nursing facility transitioning from Medi-Cal fee-for-service to a managed care plan will automatically have 12 months of continuity of care for the placement, as long as the facility is licensed by the California Department of Public Health, if they're certified to receive Medi-Cal payments, and as long as there's not any major quality issues with the facility, that person, the resident, can still stay in that facility and receive care. So where there might be a concern is what happens after that 12 months. So following their initial 12-month continuity of care period, members can request an additional 12 months of continuity of care. following the process established by all plan letter 22-032. And so you can Google that APL 22-032 if that's something you're interested in, or you could also call health care options. So a member newly enrolling into a plan and residing in a SNF after June 30th, 2023, do not receive the automatic continuity of care and instead have to contact their plan to request the continuity of care. So things to consider: if discharged from a hospital into a SNF, SNF is short for skilled nursing facility, and they're going to have to choose a facility that's contracted with their Medi-Cal managed care plan. So that may actually limit their options. That's something to consider. And so you're going to want to find out what facilities contract with your managed care plan. And then also, I think for the first 12 months after people are transitioned onto managed care, there probably won't be much going on, but the concern would be, what happens after the 1 year? What if the plan doesn't authorize further treatment at the skilled nursing facility? Or what if that facility decided not to contract with the managed care plan? At that point, you're going to have to look at your options. If it's a denial of treatment or a denial of further treatment at the skilled nursing facility, the beneficiary has the right to appeal a denial of services or coverage. If it's that the plan and the skilled nursing facility aren't contracted with each other, then you may need to look at getting a medical exemption request fee for service, which might be difficult to do. And worst case scenario, they may have to either try to switch their managed care plan to be the managed care plan that's covered by that facility, or they may need to move. But if this comes up, definitely give us a call, and then we can walk you through what your options are as far as appeals or submitting medical exemption requests. So there are rights outlined for the different types of plans. So it can get complicated because there's different types of plans. So I'm not going to get into it here. But if you are denied services, you would get a notice of action explaining what your rights are to appeal or to file a grievance. And so when that does happen, or if that does happen, you want to take action and exercise your appeal rights and grievance rights. And you can give us a call if you have an issue with that. Who can help you with your questions or concerns about choosing a managed care plan, about why you got put in a certain plan, about how to change it, why your Medi-Cal services are changing, or if you want to see what other health plans are available, you can call healthcare options, you can call the managed care ombudsman, and the Medi-Cal managed care health plan directory. So those are great resources for you to call if you need help or more questions, have questions about the plans. So one of the benefits of CalAIM would be enhanced case management. So this is going to be a service provided by the managed care plan, and it's going to be only available to specific populations. So this is comprehensive case management and intensive coordination of health and health-related services to high needs individuals. Targeted populations include individuals experiencing homelessness, adults at risk of avoidable hospital or ED utilization, adults at risk for institutionalization, and adult nursing facility residents transitioning from the skilled nursing facility to the community. Individuals can be referred to enhanced case management by their provider, or the managed care plan, or self-referral, or a family member can refer you. It's not available to people, beneficiaries participating in Cal Medi Connect, care Medi-Cal plans, PACE enrollees, or individuals in 1915C waivers. But if you happen to change out of those plans, then you would be eligible. The reason those people are not eligible is because they receive comparable services through the current plans that they're in. So enhanced case management would provide you with one case manager who would meet you where you are. So for example, if you were homeless, they would be able to meet you where you're currently residing. If you're in a skilled nursing facility, they can meet you at your skilled nursing facility, and they help assess what your needs are and help connect you to services. Community supports. So community supports can be a great benefit. There's 14 optional community supports. So optional means that not every county or managed care plan is going to provide them. And so these are the additional 14 community supports. They're being provided. So each managed care plan is deciding whether or not they're going to provide these, and they're implemented at different times. So it can be confusing to determine, what's available to you. And I will get into that on another slide, but the ones I'm going to focus on today are nursing facility transition, diversion to assisted living facilities. So that basically means to try to prevent placement in a skilled nursing facility, that the plan would pay for assisted living. And then community transition services, nursing facility transition to home. So that would be for a skilled nursing facility resident who wants to come back and live in the community. And personal care and homemaker services, that would be assistance in the home, providing assistance with activities of daily living, hygiene, cooking, things like that. So eligible populations for nursing facility transition, you have to have resided for over 60 days in a skilled nursing facility, willing to live in an assisted living facility, and able to safely reside in an assisted living facility. Nursing facility diversion, you have to be interested in remaining in the community, willing and able to safely reside in an assisted living facility, and receiving medically necessary nursing facility level of care, or meet minimum criteria to receive nursing facility services. So if you're receiving nursing facility transition diversion services, one of the things they could do is assess your housing needs and present you with options. So they can figure out what kind of place you may need. So for example, if you have mobility issues, they'd need to assess what you would need at the residence. They could help you with a deposit. They can communicate with the facility administration, coordinate move-in, and help the beneficiary retain facility housing. So for example, if there's some issues and rate increases or evictions, they would help work through that process as well. Other services that the managed care plan could offer is covering ongoing expenses for members receiving care in an assisted living facility, personal care homemaker services. So sometimes somebody may be in a skilled nursing facility and they are going to apply for in-home supportive services to provide them with care once they get home, but they can be given personal care and homemaker community support services temporarily to help get them through the time where they're waiting for the IHSS in-home supportive services to be approved and implemented. So how can you find out if these services are available to you? There's a spreadsheet that you can go to where it will tell you by county and plan what's available. I do find this chart hard to read. So if you already know what managed care plan you have, it is easier to go to the managed care plan website and look at what they have available it's usually more consumer friendly. But when you may want to use this chart is if you're choosing a managed care plan and you want to choose one with some services available, then you may want to use that spreadsheet. And of course, you can always call us if you have questions as well. Okay, hopefully I didn't give you too much of a headache talking about CalAIM. Hopefully people can get additional benefits with the program. So if anyone has any questions.
Yes, we have quite a number of questions. So I'm going to go through a few of them right now. The first, so does living with adult children affect Medi-Cal eligibility, or does the elderly person have to live on their own? That's a great question because it comes back to what Medi-Cal considers a household. And Pauline, I don't know if you want to stop sharing your screen for this part. So if you have an elderly person who plans on applying for Medi-Cal, they live with their adult children who are working or have their own family, as long as the adult child is not, a dependent themselves, then only that person, only the older adult applying for Medi-Cal would be listed on the Medi-Cal application. Or for example, the couple would be listed on the Medi-Cal application. So when Medi-Cal uses the term household, they don't always necessarily mean literally all the people living in your home. So if you have a person, my dad lives with me, my husband, and my daughter, but he is 85 and needs Medi-Cal, he would apply for Medi-Cal on his own. My income, my family's income would not be taken into consideration. He would only be looked at for his own income and assets, which is good. That's a helpful thing for most people. If someone needs to sell their manufactured home to fund independent living or assisted living, are the proceeds from the sale exempt? Do they count towards the asset limit? So I think we can maybe take out the word manufactured here, because manufactured and mobile home issues really kind of more pertain to recovery. So if you sell your home, would that make you ineligible for Medi-Cal? First thing that I would be talking to somebody right now about in early 2023, headed towards the elimination of the asset limit, is what's your timeline? Because do you plan to purchase another home? So I'm selling my home this month. Medi-Cal allows you to keep, Medi-Cal will not count the proceeds from the sale of a home if you purchase a new home within 6 months. Is that right, Pauline? I think so.
Yeah, it's 6 months. It's exactly 6 months. So if you go, if you're at the 7th month, unfortunately, you would lose eligibility.
But in 2024, that will not be a factor anymore, because you can have, unlimited assets in the bank. Where does the Medi-Cal patient's income go towards the nursing home or the community spouse? I'm assuming that this person is talking about a Medi-Cal patient living in a nursing home who has a spouse at home who's not on Medi-Cal, because we talked about spousal impoverishment during today's presentation. So, the answer is not an easy one, because it really depends on what the income of the community spouse is, whether it is above or below that limit that's set for community spouses, which is currently $3,716. So if the community spouse's income is less than that, then yes, some of the Medi-Cal patients' income could go to them. Or it is possible that they could also have a share of costs that they pay towards the nursing home. Often what we see with people when one of the spouses lives in a nursing home is that they are able to allocate some income home, but they still may have a share of costs. So it could be both. So in that scenario, I'd really love to know more about the specific income of each person. Not right now, but feel free to follow up with me. about each person and kind of walk through the calculation.
Maura, can I ask a question?
Sure.
Back to the selling of the home. If my mom sells her home in 2023 to fund moving out of the home and into a independent living, are those monies exempt, or does she have to rebuy a house in 6 months? I didn't quite understand.
So Medi-Cal, if she's not purchasing a home within 6 months, then it's possible she could lose eligibility for a period of time in 2023. So if she were to sell the home today, it doesn't matter that she intends to use those funds to fund independent living or assisted living. If she's not planning on reinvesting them, then it sounds like it might be better to wait till later in 2023, when the 6 months would run her into 2024, when her assets will no longer be a factor.
Oh, so she should sell from July on.
That sounds like it might be a better, work out better, and she wouldn't maybe put her Medi-Cal eligibility at risk.
Good strategy. Thank you.
Do you need to take periodic payments from an IRA if the IRA is under $130,000? Great question. No, that's another way of really trying to expand the way that we think about the asset reserve. So someone with a very small IRA, if it fits within their $130,000 asset reserve, I would just double check that they're, what else do they have in their savings or their checking, and really add it all up. But you are correct, they don't need to take periodic payments if the IRA is very small and it fits within their property reserve. Would the value of a second car and second home be non-exempt? Not exactly. So it really depends on what the value of those home, the second home or second car is, whether it fits in the person's property reserve. But let's say you have, your primary residence, but you also own a home that, the value of the second home does matter. So let's say the value of the second home, it's California, it's worth $600,000, then yeah, it would definitely be counted. It would make you ineligible for Medi-Cal. And so some considerations are what's the timeline again? How soon does this person need Medi-Cal? Is there an option to wait until 2024? Then we kind of need to talk about transfer penalties and what the intention of using Medi-Cal might be. Pauline, for the boarding care deduction, does it matter if my mom is in an independent living versus boarding care versus assisted living?
Oh, well, so there is a definition that the Department of Healthcare Services used. So assisted living is also considered residential care for the elderly. Independent living, I don't know I don't think that meets a definition. Do you know, Maura? I have to look it up, but I don't think so.
I don't think so. It would really come down to how they're licensed. So if they're licensed through community care licensing, there is a website where you can check, but it would be a licensed, boarding care, assisted living. Sometimes facilities use those terms very interchangeably, RCFE. So it would versus like a senior housing complex would not, they would not be eligible for the boarding care deduction. Pauline, is it true that Medicare will do crossover billing directly to the managed Medi-Cal plan?
So in some cases, Medicare will actually not even bill Medi-Cal, but it would never fall on the patient. The patient should never have to pay, and in many cases, it would be Medicare covering it, but the participant or the Medi-Cal beneficiary should never have to pay. But there are some state law and Medi-Cal reimbursement rates where the state or Medi-Cal isn't required to pay anything in many cases.
Okay. Will there be a database eventually that shows which licensed skilled nursing facilities are contracted with which Medi-Cal managed care plans?
Not that I know of. I would say for now, the best way to find out would be contacting the managed care plan. At this point, from what I've heard, the managed care plans are still building up their network. So they're working on contracting with more providers. So I would say for the most up-to-date information, I would contact the actual managed care plan. At some point, there should be something available so that consumers can figure out how to choose which plan. And when we find that, we will share it. But as far as I know, there isn't an easy way to sort that out. But if I find anything, we'll definitely put it on our website.
Does it matter where the person's assets are located if they're located outside of the US? It doesn't necessarily matter, but it doesn't make them not countable. I probably could have said that in a better way. Will Medi-Cal count someone's assets if they are outside of the US? Yes, they will ask for the estimated value. They will do conversion. There's a family in Northern California right now. Their accounts are in India. And so they look at the rupee conversion rate and then do the calculation. So there was another applicant who owned an apartment in Paris. And so, you know, what can be challenging when someone owns property in another country is getting the value of, you know, getting a statement, depending on how that local government works, getting what the approximate value of that property might be. If a consumer selects a managed health plan, can they disenroll and enroll to a PACE program?
They can if they're within the PACE program's service area. So that is an option for people if they want to enroll in PACE instead of the current managed care plan they're in. And then PACE would be, that would be a managed care plan for your Medicare and Medi-Cal.
Can personal care community supports for help at home be available upon discharge from a nursing home to home while a resident is awaiting IHSS approval?
Yeah, so that would be one of the best ways it could be utilized. But again, the limitation would be, does the managed care plan provide this service? And are they going to approve it for the beneficiary? But that would be a great utilization of the personal care community supports for somebody who is waiting for IHSS approval. And of course, it's going to cost the state less money to provide those services at home than to keep somebody waiting in a skilled nursing facility till they can get the care they need at home.
Are IHSS payments counted as income? It depends on who you are caring for. So my understanding is that if you live with the IHSS beneficiary and you yourself need Medi-Cal, for Medi-Cal at least, the income should not count. So I think many people who end up attending these events with us or calling Canner, they're family providers. So if you live in the same home as the IHSS recipient, most of the time the income is not counted. It really does depend. We'd want to know more.
It depends on the relationship, right? So it's if you're the parent of a dependent adult or a dependent child, your income wouldn't count. And if you were the spouse, it wouldn't count. I'm not sure if it was and I mean count towards Medi-Cal, and then whether it counts towards your taxes is a whole other issue.
Okay. Great question from Virginia. Is there any advocacy about changing the income limits? Yes. Last year, Canner participated in with a group of other statewide or local and statewide advocacy organizations on AB 1900, this was an effort to change the maintenance need. So we went through how does someone qualify with a share of cost, and the state uses a very outdated figure of $600 for your living expenses. I'd love to know where in California people can live for $600. It's probably not somewhere safe or particularly healthy. So AB 1900, our effort was to raise the maintenance need to on par with whatever the income limit is for age and disabled federal poverty level Medi-Cal. So for example, if AB 1900 had passed last year, someone would be able to keep up to $1,564. Still not a lot of money, but definitely a lot better than $600. So the way that the legislature and the governor decided to move forward with AB 1900 is that they will look at it again in 2025, and depending on appropriations, they may enact that change in 2025. So we haven't given up advocacy. There definitely is a huge effort around this, increased awareness. And so I think it's important to talk to your legislators and your representatives about the need to increase the maintenance need. Pauline, what is the name of the department at the managed care plan that I can ask about which ALFs are in their nursing home diversion to ALF program?
So each managed care plan is going to be structured in their own way. I would recommend, what I found the easiest was to go on their website, search community supports, and then they gave you information about how to get more information from their managed care plan. So I would suggest going that route. For me, that was the easiest because, you know, different managed care plans might call their departments different things.
A dual eligible who is discharged from a Medicare covered SNF stay can access Medicare's home health benefit as long as there's a skilled component to it. Okay. Thank you for that information. Often though, we do see that Medicare's home health coverage is not sufficient to really meet the needs of people coming out of nursing home care. I know for my husband's uncle, who was recently faced with being discharged from the hospital, they were offering something like, it was about 2 to 4 hours a week. And so that just was not sufficient for him. If someone is receiving enhanced case management services, would they need to disenroll with ECM before enrolling in Medi-Cal waiver programs like ALW and MSSP? What is the best way to determine if someone is receiving ECM?
So if you don't know, I mean, you would probably know, but if you don't, you would just need to ask the managed care plan. So the thing about CalAIM is really most of the power is in the managed care plan's hands. So, you know, in one way, most of the time when you ask who should we ask, it's the managed care plan. That makes it simpler, but they also have a lot of the you know, authority to approve or not approve, but that's who you would get the information from. If you want to know if you're in enhanced case management, you would contact the managed care plan. And then if you were going to go into one of the programs, like a 1915C waiver or something like that, that provides its own type of enhanced case management, yes, you'd need to disenroll from enhanced case management before receiving those services. The department, I think, is still kind of figuring, the Department of Healthcare Services is still kind of figuring out, you know, how that's going to work, how they're best going to communicate that to each other if the beneficiary, you know, hasn't figured out. Many beneficiaries might not even realize they need to disenroll. So, you know, it's hopefully somebody does realize they need to disenroll, but if not, it might be figured out at some point and they could disenroll you.
Do we know if the assisted living waiver will be expanding to other counties?
So right now, the Department of Healthcare Services is looking to integrate the assisted living waiver into the existing home and community-based alternatives waiver. So it will actually, it'll be absorbed into the home and community-based alternatives waiver. The home and community-based alternatives waiver is statewide. So they are looking at expanding, having more facilities in different locations, so that they can provide the service in a broader area. But from what I hear, it sounds like it will be a slow transition. So nothing immediate, but over time, there will be more providers in more service areas.
Okay, well, I want to thank everyone for your time today and joining us. We've now reached the end of our presentation. A lot of really great questions. We know this is such a huge issue. We do plan to hold additional events in the coming months. I've dropped a link into the chat for our next presentation, which is scheduled for March 22nd. This is really focused for consumers, family members, advocates. It's going to focus on home and community-based services that are available through Medi-Cal. I know a lot of you, your questions were about HCBS programs. And so we're really going to delve into what each program looks like, what kind of services you can receive, and how to apply. So there is a link to register for that event so that you can put it on your calendar now. Pauline, any last comments before we end?
Just, if you have follow-up questions, you can give us a call. And if we can't answer your questions, we can at least direct you to who should be able to. So feel free to reach out.
All right. Thank you, everyone. Have a great rest of your day, and we look forward to seeing you at future events. Goodbye.